Thank you so much, Dr. Miranda, and thank you to the Hispanic MHCC for inviting us to present in this very important panel today. I will start us off presenting on what trauma is and specifically how it can manifest among unaccompanied minors. And more importantly, what are some tips and strategies that we can incorporate for bolstering resiliency and psychological recovering these minors. A little bit about me. I'm an assistant professor and bilingual clinical psychologist at the National Crime Victims Research and Treatment Center in the Medical University of South Carolina. And broadly, my research and clinical practices focuses on how do we address mental health disparities among underserved populations, in particular Hispanic and Latinos, and how do we take what we know works out in the communities through innovative methods such as telehealth and other practices. I currently have a SAMHSA-funded project in Puerto Rico promoting psychological recovery after Hurricane Maria in youth, and I previously co-directed a similar project funded through USAID in El Salvador. I also am an expert in trauma-focused cognitive behavioral therapy, psychological first aid, skills for psychological recovery, and co-direct the World Changers Lab with Dr. Regan Stewart at MUSC. So it's a pleasure to be with you today. My disclosure is that some of this work and just the entire lab is funded by a National Child Traumatic Stress Network grant from SAMHSA. So what are our objectives for this first presentation? I hope that by the end, everyone will have a common definition of what trauma is and what it's not, some basic common reactions, emotional, behavioral observed in children and youth after traumatic events, and more specifically, walk through the experience of an unaccompanied minor prior to entering the United States, during entry, and upon integration into the community with their sponsors and communities. And what are some evidence-based tips and strategies we can do to help these minors thrive? So to start us off, what is trauma? So according to the DSM-5, trauma is an exposure to an incident, event, or situation in which several things happen. Number one, there's significant fear. You feel like there's a threat to yourself or someone else, and or a serious physical injury has occurred. There's an actual death, or there's been sexual violence. And this is important. This event does not have to necessarily occur to the minor. It could have been something that he or she witnessed happen in front of them to someone else. It could have been something they heard of, or it could be exposure to repeated adversive details of traumatic events, such as what first responders experience or 911 operators experience. A trauma is very different than a stressful event. So for example, if today, this morning, you were running late for a meeting and you were very stressed out about that, that would be a stressful event, versus a traumatic event is an event in which you felt like your life or the life of someone else was threatened or in danger. Some examples of potentially traumatic events, and this comes from SAMHSA's trauma-informed approach, key assumptions and principles, fall into major categories. For example, abuse. This could be emotional abuse, sexual abuse, physical abuse, exposure to violence in the home, witnessing people around you fight, or even cyberbullying. Then we have traumas that center around loss, such as the death of a loved one in a tragic way, or abandonment, neglect, or loss to in terms of personal belongings or your way of life, be it through natural disasters, war, torture, violence. And then we have chronic stressors such as poverty, racism, invasive medical procedures, community trauma, historical trauma, family members that are engaging in risky behaviors that put at risk the safety and perceived routine of that minor. And so it's really important to keep in mind that there's many events along the continuum that could be potentially traumatic. And we say potentially traumatic because the experience of one of these events or accumulation of them does not automatically mean that that minor will experience negative effects. We have a lot of youth who are resilient, and what that means is despite adversity, they thrive. So we have to be sure to not pathologize trauma. Some statistics. So approximately half of all youth in the United States will experience at least one potentially traumatic event before they turn 18. So this is really important. And trauma increases the risk of developing a host of mental health problems and concerns. And it's important that, unfortunately, trauma exposure is not created equal. We have lots of data showing that racial and ethnic minority youth, Hispanic, African American populations, Native American youth disproportionately experience trauma. And this is for a number of reasons. We know from the literature that greater exposure to poverty, lack of access to education, you're more likely to potentially live in an unsafe neighborhood, have less access to resources, be raised in a single parent home. And this all contributes to your increased risk of experiencing trauma. When children are impacted by these life events, that's traumatic events where their perceived life is in danger or someone else's life is in danger, or they're in chronic stress, they're more likely to experience a number of mental health conditions, such as post-traumatic stress disorder, in which we see kids who are having intrusive memories, nightmares, flashbacks. They feel anxious all the time. They feel unsafe. They can't sleep. They can't eat. Or they get depressed. They feel like life is not worth living. They may experience increased substance use or self-harm. And it's interesting, studies across the lifespan indicate that the more exposure to trauma a child experiences, the greater risk of experiencing additional victimization, themselves engaging in risky behavior, smoking, using drugs, and even it's been linked to cardiovascular disease, obesity, and premature death. So this is all very important to address. And I just want to briefly highlight what happens in the brain when we experience trauma. So it's really cool. By the time we're born, human beings have all the billions of neurons that they're going to have in their lifetime, but it's up to the environment to really shape what connections form. So the more interactions we have, the most exposure we have to our environment, that's what's going to shape how our brain works and connects. And this is particularly important because with exposure to trauma, events where this child thinks that their life might be in danger, where they're seeing abuse, they're seeing violence, they're fleeing war, they're fleeing gang-related activity in their home country, they're not connected to their caregivers, they've left behind their way of life, we're going to see a couple of things happen that are really important, and these are all biological. So the first thing that's going to happen is that the alarm system, the car alarm system of our brain, the amygdala, it's always going to be firing, alert, alert, danger. And that amygdala has a direct highway connection to this top part of our brain called the prefrontal cortex, whose job is to help us act and follow social norms and listen and learn. And that's going to shut down because it's in panic mode. And on top of that, the hippocampus, it's kind of the amygdala's cousin. It's in charge of memorizing everything that can possibly do you harm and helping you avoid it. So all of a sudden, this child is going to be avoiding anything that reminds them of their trauma. It's going to be in high alert anytime they perceive danger. And finally, this is all going to cascade into stress hormones like cortisol and adrenaline rushing through their bodies, which we know impacts their ability to regulate all of their mood, all of their ability to produce insulin, to keep a healthy body homeostasis. So this is really fascinating, and it happens in the brain. So what I want to highlight here is that trauma is like a panic button or a car alarm going off nonstop in these children. And we have to shift our perspective to the following. Instead of asking, what's wrong with this child? Why can't he or she behave? They're safe now. They're in this country now. They should be okay. Well, we have to remember that this panic alarm is on. And the question really is, what has happened to this child? And how can we support them? And we have to recognize, too, the impact of trauma on development. So in young kiddos, we know that traumatic events interfere with their development. These neurons are not going to fire the same way, and it can affect their ability, their intelligence development, their ability to regulate emotions, their ability to pay attention. So we see kids running around, maybe misbehaving, not following instructions, or frankly, completely blanked and checked out. By school age, these kiddos also have less ability to manage fear. It's like their prefrontal cortex is shut down and they can no longer manage their anxieties. They might revert to old behaviors like wetting the bed or not being able to communicate effectively. They might be impulsive. And in adolescence, trauma has been shown to impact the way that teens appraise danger. They might get into risky situations without realizing that there's risk, or they might be very impulsive and not understand that their behaviors have consequences, or they might have trouble learning abstract problem solving. So these are all the impacts of that panic button going on from a very early age. On top of that, they might be fearful of situations. You might see kids cry unconsolably. You might see kids that you touch them and they jump, they get easily startled, or they don't trust anyone, or they have thoughts that the world is not safe, or they have trouble making friends. So these are all things that we have to keep in mind when we're seeing that child who's crossed the border, is all alone, feels scared, and that panic button is activated. And it's sad, but it's true. We have disparities in trauma exposure. Hispanic and African American youth endorse higher rates in trauma than compared to Caucasian youth. And Hispanic females in particular are a particularly vulnerable group, with 1 in 3 endorsing some form of trauma exposure. And on top of that, Hispanic Latinos in the US are less likely to have access to mental health care that's culturally appropriate, linguistically appropriate, evidence-based. And when they do connect to services, they're more likely to drop out. So we have a problem here. What have unaccompanied minors experienced? Let's walk through this. It's lack of consistent caregivers, homelessness, lack of access to basic need and food, witnessing multiple violent events. In fact, that's what prompts most migration. And on top of that, many are forced into forced labor, trafficking. They lack medical care and are deprived of an adult caregiver who can consistently protect them. During migration, they may experience very hazardous train or bus rides. They may be sexually assaulted. They may see murders. They may be left abandoned in a desert with no one to care for them, without water or food. They may have, prior to that, experienced that in their hometowns, and now they're separated from their family members. And on top of that, there's a sense of loss of community and connection. And once they cross the border, they're detained. And during detention, there could be unsafe conditions. There could be uncertainty about the future, even something as unfamiliar as food. What is this that doesn't seem familiar to what I'm used to? Stomach issues, uncertainty, risk of exposure of further trauma within detention centers. When they're reunited with their sponsors, they might not recognize this family member they haven't seen in years, or might want to be back with their caregivers that they left back home. They might be having trouble adjusting to new expectations of regulations and school attendance, etc. And most important, sponsors may not be able to understand what has happened to their child or their family member or this kid that they're harboring. So there's just a lot of things that we need to understand these kiddos are going through, including differences in language, culture, etc. And briefly, what I want to mention about school, I work a lot with unaccompanied youth, and one of the things that I hear a lot is teachers not really understanding why this kid can't pay attention, why they're not understanding or comprehending, why they're alone in the lunch table, and we need to really have that trauma-informed lens. So finally, what can we do? These are some very quick, easy tips and strategies for us to help unaccompanied youth the moment that they come into our care or that we interact with them. Number one, put your trauma-informed lens on and realize everything we talked about today about how trauma impacts mental health and behavior and the brain. Number two, listen first. Your job is not to give advice, your job's to listen. And it's all about making statements that helps that kid know that they're important, that they're cared for, and that you're believing them and you're here to help them. Such as, I can imagine this has been hard for you. Thank you for sharing that. You must have felt angry and scared. I appreciate you sharing your story with me. That was very brave of you. I'm here to support you and connect you with services. Instill hope. Saying things such as, we're here to help, you're not alone, is really important to help that youth understand that there's a process here, but they're not alone. We know from the data too that instilling hope is very important for promoting psychological recovery and resiliency in youth. Use certified interpreters. Please remember that it's not appropriate to ask a minor to interpret for another or a family member to interpret for another family member. We need to use certified interpreters, preferably who are trauma informed. It's the equivalent of you would never want to interpret a medical diagnosis of a family member. You're too involved. So let's not involve children in that process. It's unethical. Instill a sense of safety. Develop a safety plan in the immediate term and long term. Minors need information about what's happening to them and what's going to happen to them so that they can self-regulate and know what the plan is. And finally, offer developmentally appropriate psychoeducation to caregivers you work with on what trauma is, what they can expect to see in these children, and some basic resources. And I'll give you a resource at the end where you can find this. This is my final slide. You can practice relaxation strategies with these kiddos, such as deep breathing. And it's really easy. You just take a deep breath through your nose and exhale slowly through your mouth like a balloon that's deflating. And doing that a couple of times can help self-regulate, or you can practice closing their fists and gently opening them and just practicing what's called progressive muscle relaxation. Finally, we need to help these minors build healthy social connections. Separating minors from their caregivers or their siblings is traumatizing. This is the cornerstone of health, is healthy social connections. So we need to rebuild that. We need to encourage healthy expression of emotions and positive activities such as exercise, music, and sports. And finally, take care of yourself. Working with unaccompanied minors or trauma-exposed populations is not easy. If you're noticing you're irritable, checked out, avoiding work, having nightmares about the stories you're hearing, or feeling just a sense of apathy and hopelessness, it may be time to seek support from your colleagues, your supervisors, or seek professional help for burnout. And please do preventative work, such as eating healthy, sleeping, getting enough exercise, and just taking time for you that doesn't involve this hard work. For additional resources, especially on how to provide psychoeducation on trauma to sponsors or caregivers, please visit nctsn.org, and never doubt that a small group of thoughtful, committed citizens like you can change the world, and really that's the only thing that ever has. So thank you so much. And I'll leave Dr. Hansen.
Yes. Thank you so much, Dr. Orengo, Aguayo. We have a 5-minute Q&A. If you have specific questions for Dr. Orengo, you can use the question log. And Cindy, you can tell us if we have questions for Dr. Orengo. We will give you a minute to type in your questions. We don't have any questions for now, so please welcome Dr. Rob Hansen, and then we will do the same Q&A at the end, 5 minutes. Thank you.
Dr. Hansen, are you having issues with the presentation?
Oh, I'm sorry.
I cannot see the screen.
You cannot? Can you see it now?
No, let me go ahead and try that again. Yeah. Should be able to do it now.
Okay. I clicked on show my screen. So nothing is showing up right now. So now it's not letting me click on any of the parts of the go-to meeting.
Yeah, Macs are like that sometimes. Let me see if we can just share our screen and then we go from there.
Okay, thanks.
So while that's worked
Christine,
out,
it's gonna, sorry.
okay. I noticed some
I was gonna
questions
say,
came in, but yeah.
sorry. I was just gonna say Christine is gonna be handling the slides. So when the
Okay.
slides come up, just so you know, you can just let her know when you want to click the next slide.
Okay, okay, thanks. Yeah. Okay, now I can see her. Okay.
Can you see it? Display setting.
Yeah, I think I can, yes. Yeah. Okay, thank you very much. All right. Hello, everyone, and thank you so much for having me. Hopefully you can hear me okay and see me okay. It's a joy to be with you today. My name's Rob Hassan. I'm an assistant professor in the Department of Social Work at Providence College in Providence, Rhode Island. And the name of my portion of today's webinar is Mental Health Assessments for Unaccompanied Minors in the US. And I don't have any conflicts to disclose today, so we can go to the next slide. And some learning objectives. So there's 3 things that we're going to focus on for today. The first, participants hopefully today will learn about how mental health assessment has been used in research to understand the complex psychosocial needs of unaccompanied minors. The second is that we're going to learn about assessment strategies that can help identify complex mental health needs of unaccompanied minors. And then third, I'm going to share a little bit about one particular standardized measure of behavioral health, the Strengths and Difficulties Questionnaire, and how that can be used to identify symptoms of psychosocial distress and prosocial behavior that unaccompanied minors may experience. So this is hopefully going to build on Rosaura's, Dr. Orengo's wonderful work in the first portion of the webinar. Okay, so some things about mental health assessment, and Cindy, you can click through because I have some animations to make this a little bit more. Yeah, there we go. Great. Thank you so much. So let's start with a definition. What does assessment mean? How do we define this? So assessment is an ongoing information gathering and decision-making process to help clients identify their goals, strengths, as well as their challenges. This is our way as clinicians and social service providers to build a relationship with a client and then help them understand and articulate what their strengths are, what their unique features of resilience are, but then also to help them identify some of their challenges. This is not a one-time event. Assessment is ongoing, and it's in collaboration with clients that's based on the heart of our work, which is the relationship. Data in an assessment is gathered in various ways, verbally, through conversation with a client, non-verbally. Sometimes we might make observations of a client when we're sitting with them. We may be observing fidgeting behavior, or perhaps involuntary movements of their extremities. Their facial expressions can be incredibly important for helping us understand how they are doing at that moment. And then at times, assessment may involve members of a client system, such as their family. And one unique feature of unaccompanied minors is that they may be separated from their families or caregivers when we are meeting with them. So that is oftentimes not a part of assessment that we can engage in. And then the final portion is that mental health assessment may involve standardized measures of health and mental health to give us a more focused view of specific features of an unaccompanied minor's well-being. So Cindy, I think we can go to the next slide. And this is building on Dr. Orengo's work. So one important component of assessment is using a trauma-informed lens, which is recognizing trauma's role in an individual's life and how that can impact multiple domains of someone's functioning, including physical and emotional well-being, including our neurobiology, which Dr. Orengo spoke about in her portion. And this can also impact our ability to engage in interpersonal relationships with grown-ups in our lives or with our peers at school. And this requires a shift to ask clients what happened to you instead of what is wrong with you. And some other components include shifting from a deficits-based assessment to recognizing the inherent worth and dignity of individuals. And that's a key component of trauma-informed assessment. Some cross-cultural considerations. So when we're meeting with unaccompanied minors as clinicians and as service providers, clinicians will have great benefit to having specialized knowledge and understanding about histories, traditions, specific values, and family systems as they relate to clinical practice with individuals, families, and groups. So let's focus in for a moment on the unique context of unaccompanied minors. Clinicians will have great benefit to understand specific traditions and values, as well as the history of an unaccompanied minor's country of origin, and that will help us understand the circumstances that may have led to them arriving to the United States. In addition, it's important for clinicians to have awareness of how different features of discrimination and oppression in the context of the United States may impact a minor's ability to navigate service networks. So clinicians should have awareness of how racism, sexism, ageism, heterosexism or homophobia, anti-Semitism, ethnocentrism, classism, and disability-based discrimination, how any of those can negatively impact a client's mental and emotional well-being. And importantly, these features of discrimination and oppression do not necessarily impact minors equally or in the same way. And that's where assessment comes in great importance in understanding these in each context. So now I'm going to provide some research on cross-cultural mental health, and I'm first going to start with a study that's looking at different profiles of trauma symptoms in a population, in a sample of unaccompanied minors in the United States. And just as a background, the DSM-5 has 4 main profiles of symptoms for PTSD, and these are categorized into 4 clusters of symptoms. The first cluster is intrusion symptoms, nightmares, flashbacks. The second cluster are avoidance systems, trying to avoid or isolate from scenarios or settings that may be a reminder of a traumatic event. The third are changes in cognition or mood. And then the fourth are arousal and reactivity symptoms, being hyper reactive to different traumatic stimuli. So these are the 4 clusters of trauma symptoms that I examined more closely. And then this was a study that I conducted with some colleagues looking at trauma symptoms and unaccompanied children. And this study was seeking to answer 2 specific research questions, and this is allowing us to assess trauma symptoms a little bit more deeply. The first research question that we tried to examine is the rates of PTSD, of post-traumatic stress disorder, in this population of unaccompanied children. And the second, what we wanted to examine is how unaccompanied children exhibited symptoms of trauma, and if the way in which they exhibited trauma aligned with the diagnostic and statistical manuals conceptualization of trauma. Are the experiences of unaccompanied minors aligning with how trauma is conceptualized in the United States? So in order to answer those questions, I used the Child PTSD Symptom Scale, which is a scale using 20 items. And each of these 20 items measures different symptoms, measures symptom frequency. So on a scale of 0 to 4, 0 means the symptom is not experienced at all, and then 4 means the symptom is experienced 6 or more times a week or almost always. And the CPSS measures symptoms experienced in the previous month, and scores can range from a minimum of 0 to a maximum of 80. And the greater the score, that's indicative of greater symptom severity of PTSD. So for my first research question, rates of PTSD for unaccompanied children. For the overall sample, I found that 8.1% of all unaccompanied children in the sample met criteria for PTSD. This was quite surprising to us. This was a remarkably low rate compared to prior research and prior studies of this population. I then looked at country differences, and I focused on 3 specific countries: El Salvador, Guatemala, and Honduras. And I focused on these countries because these are the main countries of origin for unaccompanied children arriving to the US for the past several years. So I did find some differences in country of origin, and one that I'll draw your attention to are unaccompanied children from Honduras. Substantially lower rates of PTSD for children from that country, 4.2% compared to nearly 10% for El Salvador and 10% for Guatemala. Of note, these differences are not statistically significant. However, this is an area for future research to understand the more nuanced differences in these findings. For the second research question on the next slide, what I tried to see is if the experiences of trauma that unaccompanied children reported upon their arrival to the US, if that aligns with the DSM-5's definition of PTSD. So in the DSM-5, there are those 4 clusters of PTSD symptoms. And what I found is that those 4 clusters for unaccompanied children, they emerge in 3 different profiles. On that first profile, you'll see all 4 clusters of symptoms are present. So intrusion symptoms, avoidance symptoms, changes in cognition or mood, and then arousal and reactivity. The second profile of symptoms includes 3 of the 4 clusters, and the only one that's missing from that profile is avoidance symptoms. The third profile includes only arousal and reactivity symptoms, and I'm going to focus a little bit more deeply on that profile because it only included 2 items. 2 out of the 20 items aligned with this profile. And here's what we found. We found that for unaccompanied minors, that these 2 items specifically spoke to them in terms of their experiences of trauma. And those are the extent to which they get angry easily, for example, yelling, hitting others, or throwing things. And then the second is having trouble paying attention. And what we tried to do is we tried to think really deeply about what these findings are trying to tell us. And what we posited in our interpretation is that these findings can help us explain the ways in which unaccompanied children are managing their symptoms of trauma in specific contexts. So where might unaccompanied children be having trouble paying attention, and where might they be easily frustrated? And the main setting that we thought of was school. So on the next slide, we were looking at trauma symptoms in context, the unique context of schools. And what we were thinking is that when unaccompanied minors are arriving to the US, they are navigating various challenges. They're trying to learn a new language. They're trying to navigate new social networks. And then on top of that, they may have experienced different traumatic events that Dr. Orengo referred to earlier. And what we were interpreting in these findings is that trauma can disrupt our learning in really specific ways. And that trauma and that these behavioral outbursts in the classroom, such as getting angry easily or having difficulty focusing, that those behavioral outbursts could actually represent masked expressions of untreated trauma. So our interpretation is that this specific finding could be especially useful for school professionals, such as teachers, guidance counselors, or social workers, when they are seeing an unaccompanied minor have difficulty in the classroom focusing or having a behavioral outburst, going back to that question of not asking what's wrong with them, but then inviting ourselves to consider what might have happened to that unaccompanied minor that may be leading to this set of symptoms. And then on the next slide, coming to this third objective for today, looking specifically at the Strengths and Difficulties Questionnaire. This is a brief behavioral health screening tool with several versions for individuals as young as 2 years old. And for those versions, 2 to 4 years old, parents, sponsors, or teachers can complete that version. There's also versions for 4 to 10-year-olds, 11 to 17-year-olds, and then also for individuals 18 years and older. I'm going to be referring to this as the SDQ, and it's been translated into more than 40 languages. It has been used as a clinical assessment tool in a variety of settings, including outpatient health and mental health settings. And it's been used in research in over 5,000 studies and in 104 countries. So it's one of the most widely used mental health assessment measures in the world. Some additional details. So the SDQ is brief indeed, which is wonderful for clinical settings. It has 25 items that measure specific features of psychological attributes, and these are organized in 5 separate subscales. The first are emotional problems, symptoms of sadness or perhaps anxiety. These are 5 items. The second uses 5 items to measure conduct problems. So for conduct problems, these are questions looking at whether or not a minor may be having difficulty with fights at school or being truthful or honest. The third subscale measures hyperactivity and inattention, so struggles with paying attention. And then the fourth is measuring peer relationship problems. So does the minor have difficulty making and keeping friendships? And then what I particularly like about the SDQ is that it has a 5th subscale, 5 items that measure pro-social behavior. And what's really wonderful about this is that it can help us understand what is leading to an unaccompanied child exhibiting features of resilience. The items on the measure are measured using a very basic 3-point Likert style scale. So each item is either not true, somewhat true, or certainly true. And then the scales for 1 through 4, those difficulties subscales are added together to generate a total difficulty score based on 20 items. So those range from 0 to 40. And the greater the number, that's indicative of greater difficulty. And then one final note with the Strengths and Difficulties Questionnaire is that it can be particularly helpful for informing the ways in which we make referrals for unaccompanied children. So when you complete the SDQ with a minor, you may find that they don't have many emotional problems or conduct problems, but their subscale for hyperactivity and inattention and peer relationship problems may be quite high. So what that can tell us is that they may have trouble paying attention in school, and they may have trouble making and keeping friendships. So we may be making referrals for an education assessment, and then we can also be making referrals for a mentor or engaging in a recreation activity. If it was emotional problems or conduct problems, perhaps a therapeutic intervention such as individual therapy may be warranted. But I think the main takeaway with the SDQ is that when we're looking at these different subscales and when we're looking at the intricacies of the scale, it can really help us as service providers make targeted and informed, trauma-informed referrals for the minors that we're working with. What's also really unique about the SDQ is it has been used to assess mental health and behavioral health in samples of unaccompanied minors, mostly in the context of Europe and the United Kingdom. For example, research with 166 unaccompanied minors in Belgium found that almost 30% reported emotional problems and 12.7% reported peer problems. So almost a third reported difficulties managing their emotional symptoms, and then more than 1 in 10 reported challenges navigating their peer networks. And then one more study in the United Kingdom on 71 unaccompanied minors found that nearly 30% reported emotional problems, 23.1% reported peer problems, and then half of that sample reported hyperactivity problems. So here what we're seeing is that emotional problems and peer problems are particularly unique to this population in these samples in the United Kingdom and in Belgium. And one area for new research is looking at how the SDQ has been used for assessment with unaccompanied minors here in the United States. Most of this research has been in Europe. So some takeaways from today. So one, we need to keep in mind that assessment is an information gathering process. It's a way in which we can use our relationship with a minor as the foundation to learn information about them, to learn about their strengths, their needs, and what their hopes are. We also know from research that unaccompanied minors exhibit unique profiles of trauma symptoms, those hyperactivity and reactivity symptoms that I mentioned earlier. And this can help clarify their needs in specific contexts, for example, the context of school. And then finally, the Strengths and Difficulties Questionnaire is a standardized behavioral health measure, and this can be used to help clarify an unaccompanied child's strengths and needs, as well as support data-driven referral processes from a trauma-informed perspective. So I think the next slide has a variety of references that I use to inform my ideas and to organize my thinking. And then the next slide, I think, is an opportunity for us to engage further using the question log to type in your question if you have one. And I'm looking forward to engaging with you further. Thank you so much for having me.
Thank you so much, Dr. Hassam, for an excellent presentation. We'll have the 5-minute Q&A. Please type your questions in the question log. Cindy, can you let us know if we have specific questions for Dr. Hassam?
Yeah, we do. We have a couple, so let me just filter some in. So you mentioned the STQ, and someone's asking if any school staff administer this, like, if they can administer the STQ as a school staff.
That's a wonderful question. So the SDQ has been created into 3 different formats. One is a self-report version. That's completed directly by the minor or by the individual. The second is a parent or sponsor version, so the parent completes it. And then the third is a teacher version. So there's a special version of the SDQ for teachers and educators for them to use to clarify what an unaccompanied minor may be experiencing. So yes, teachers can use it.
And then regarding that same question, we have another one, says, where can they access the questionnaire? And if someone needs a special training to administer it?
Okay, so the SDQ, what I particularly enjoy about the SDQ is that it is publicly available. So you can Google it. It's the creators of the SDQ have a designated website with information on how to score the SDQ. There's information on how to implement it on that website. There's also there are also resources on research studies that have used the SDQ in all sorts of different populations, including unaccompanied minors. So if you just Google Strengths and Difficulties Questionnaire, it will bring you to the creator's website, and that's where all of the information will be for you to explore it further.
Awesome, thank you. Yeah, we had a couple of those on how people can access. And then I'm gonna make one more question. And it says, would you suggest having our unaccompanied minors take the SDQ once they are entered into our system? I guess as they receive the children?
That's a great question. So what I'm working on right now in a separate study is I'm looking at and I'm supporting an organization to implement the SDQ at 2 different time points. So the first time point is at entry upon their arrival. But then what I also think is very important is to look at the SDQ and administer it later on while an unaccompanied child or minor is still here. And what that will allow us to understand is how they are responding to different resources and services here in the United States in their resettlement community. It'll help us understand different ways in which they're exhibiting resilience, and it can also further clarify their needs. Some of those subscales will change over time as unaccompanied minors respond to their environments. Dr. Orengo spoke about how our environment is so instructive for the ways in which we respond to traumatic events, and that's one strategy that I am seeing some organizations use the SDQ and other health measures as well, using it not at just one time point, but at 2 time points to see differences and patterns over time. And thank you all so much for those questions. Thank you.
Thank you, Dr. Hassan. Please welcome Dr. Kerri Evans.
All right, are you able to see my screen?
Yes.
Yeah, we're looking at the presenter. There you go.
Okay, great. Thanks so much. Well, good afternoon, everyone. My name is Kerri Evans. I'm an assistant professor at the School of Social Work at the University of Maryland, Baltimore County. And my portion of today's presentation is focusing on strategies to increase community participation for unaccompanied kids. So just a brief bit about myself. My current research focuses mostly on unaccompanied kids from Central America, as well as other refugee groups that are unaccompanied, and is slightly expanding into immigrant families. As far as topics, it's really quite varied because I'm really interested in working with service providers and answering the questions that you all have. And so primarily my research aims to improve service delivery, to advocate for policy change, and to kind of provide some preliminary analyses that can help with grant funding so that you all can expand your services to serve more kids. Today, I'm particularly excited to be here and talk about this topic because I have almost a decade of experience as a social worker working with unaccompanied kids. And I really think that that influences the majority of the research that I do. So I have been a post-release service worker, kind of helping the kids and families reintegrate into community and with each other through the post-release program. I've done placement work both for post-release kids and kids going into foster care. And then as a program manager for the unaccompanied refugee minor and the long-term foster care programs, I did a lot of behind-the-scenes macro work in terms of quality assurance and making sure that the programs could run annually. I have no conflicts of interest to declare today. So what are our objectives? We have a short 20-minute stint here for me, but I'm going to hope to accomplish 3 things: to briefly talk about barriers and strategies for increasing participation in the community, to discuss some best practices in terms of making referrals, right? We want our referral to be a successful referral. So what does that mean? And then we'll start to look a little bit at school-based initiatives that can also lead to more participation for these kids. So first I'll jump into community participation. So these are the results from a study that we did with 79 different service providers who participated in interviews and focus groups, kind of looking at the macro level, right? The systems level, the community level. What does adjustment look like? And really, what are the barriers to adjustment kind of at that larger systematic level? So these first few things that you'll see here are probably common knowledge, right? Community fear, lack of legal status, economic struggles, and lack of insurance. But the next 3 get a little bit more interesting in my opinion. So we found that there was a lack of community preparation for English language learners. And so one example that came out of the interviews was that, you know, a youth was trying to go and enroll in the local gym, right? The local health club. But the place didn't necessarily have somebody at the front desk who spoke Spanish. They didn't have pamphlets or forms in the language that the kid could participate, right? And so I think it spoke to this idea that just our communities at large aren't always prepared enough. We saw a lack of training, and this was both professionals who work specifically with unaccompanied kids, who that's their day in and day out job, wanting more training on trauma-informed care, right? I think we all want that. We all want to be better at this. And also with understanding the nuances of different populations and specifically Indigenous populations. But they also talked a lot about training in terms of all of those other people, like the ripple down effect, right? So the folks in schools, in mental health clinics, in just community-based centers, in the court system, in the schools, right? That all of these people that touch these kids could also benefit from some level of training. And so how do we reach those folks? And so, you know, a shameless plug here, but I'm excited that you're all here today, right? You're taking that step and engaging in some of this training. And I encourage you at the end, when we share the resources for the next few, to share it with all those other people in your community. Who else touches these kids? And let's try to get this knowledge out as widely as we can. And then the last one was this idea of unwelcoming communities. And so we all know, unfortunately, that there is racial discrimination in our communities. There is biases against immigrants or against people who lack good English. People are rude sometimes. People have false stereotypes, right? And so that really kind of also came out as just a theme of why kids couldn't participate in the community as much as they wanted. And I should have mentioned at the beginning, the 79 people who participated were quite a few different groups. So parent liaisons and teachers, school social workers, mental health providers and clinicians, foster parents, agency staff at primarily UC serving agencies, legal providers. So just a wide range of service providers, but no kids were involved in these interviews, unfortunately. And I want to share just a couple quotes with you real quickly. So in terms of barriers, we heard that raids are happening. That affects potential reunifications and increases fear. And I think that unfortunately raids are common, right? This happens. But even when there aren't raids, there's still fear, right? There's still fear of deportation, a fear of engaging in the community because maybe I'm only here for 6 months or maybe it's going to be 3 years, right? When in the future will I be deported? How much should I bother to engage? And even just a fear of being found out that you're undocumented, a fear of having that label associated with you. Another quote, even something like playing soccer. They can't play soccer without legal status because of the league regulations. And I think this speaks to our role as service providers and our need to advocate in the community, right? That there's really no reason that a soccer league should have to have a regulation that says you have to be a US citizen. And if they do, we have a duty to question that and to advocate against that. And unless it's a funder rule, how do we go about changing those policies, right? How do we engage these kids more widely in our communities? So the same study, we also looked at, well, what aspects of the host community are aiding the adjustment process, right? What's working well? What practices could we spread more? So welcoming communities is a hot lingo out there, which can mean things as far as immigration laws and having support from the governor, public officials around including immigrants in the community. But it also speaks a little bit to just the interest and the willingness of community members to kind of open their arms, open their hearts, right? Let people into their businesses, into their homes to be willing to partner on things. And kind of as a subcategory to that, we found a lot of people talking about the community as being like the place that kids did things, right? So you can learn about taking the bus in theory, or how to write an email to someone, or what to say when you call to make an appointment. But until you actually do that step, you can't build that confidence, right? You can't really build those skills until you're actively practicing it. So people really talked a lot about some of the hand-holding that had to go on. You know, the first time that a teenager is going to call and set up their own appointment with a clinician, that can be nerve-wracking for people, right? And so maybe sitting with them and helping answer the questions and helping to use appropriate language, right? Or if it's a job in employment, working with your coworkers, or if you're in a place where you're interacting with clients, people coming in for a meal or coming in to shop in your store, right? Those interactions that you have on a day-to-day basis really aid the adjustment process because you're practicing your skills. And then similarly, extracurricular opportunities, which we've heard about a little bit from our previous presenters as well, that Kids need to have fun. They need to get out there and play sports or go to after school clubs or whatever it might be. The next few here, community relationships, interagency collaboration, and access to healthcare, I'll talk more about in subsequent slides. But I also wanted to mention the role of the church here. And this is kind of the idea of the church almost as an institution, right? So one-on-one, it's a place of worship. And so kids go and they can practice their religion, and that's comforting. But it can also be a sense of belonging, right? A membership, a community that you can join and that you can feel a part of. It's also a place where, you know, you can recruit foster parents or recruit donations, either financial or holiday gifts for kids. It's a space that often will rent, you know, a room for an event at a lower cost to a community agency. And then sometimes churches can offer informal mental health supports as well. So we really saw a lot of benefits from the church. In terms of community relationships, this is one quote that came up. Unaccompanied children have no established roots. Our kids don't have any type of connection with anyone. And that's a big difference from US born youth, for sure. I talk to my staff and say that every kid needs 6 adults that are absolutely crazy about them. And I think this has a real meaning in terms of service planning, right? That we all are working with these kids and figuring out who are those adults for them and helping be that liaison and making those connections. That you may be that person for a kid, and that's okay from time to time, but we want to be thinking about long-term relationships that will last beyond your service timeline. And, you know, especially if you're a caseworker and you have 20 or 30 kids on your caseload that is constantly changing over, you can't always be that long-term relationship for someone, right? So how do we work beyond service providers, but to just more neighbors, right? To people that have similar interests as the kid, to build relationships there. And then access to healthcare is a really interesting one that came up under assets in the community, right? Because by and large, I think if you asked about access to healthcare for an unaccompanied child or even an undocumented immigrant in general, our assumption would be that that's a negative, right? That there aren't enough bilingual, bicultural practitioners out there, that lack of insurance is a barrier. But what we really saw was kind of in a lot of these communities that service providers were willing to go above and beyond and tailor their services, right, to make healthcare accessible when they knew about it, when they knew there was a need. And so I'm going to share this quote here. Sexual education groups have been tailored differently. They've never been given education. We try to do it with outside agencies, but we have to be present and ease it much more easily. We address questions like, what is an STD and birth control? Even a girl with a baby doesn't know what an STD is. Sometimes it's mind-blowing. But we really have to fill in the blanks where they didn't get certain psychoeducational topics before. So this idea that in partnership, right, in working with a healthcare provider, perhaps they can provide the information that's needed, but maybe the place where we start the conversation is just slightly different for some of these kids. So I'm going to talk a little bit about some implications, some recommendations for community engagement, right? The first, of course, is to advocate for welcoming communities. And that can be, you know, at the county, state level. It can also be at the federal level, right, in terms of policy. But one way to engage in your community is to go through this certified welcoming process. So you can look it up on Welcoming America's website, and they give you a lot of tips and tools on how to become welcoming and how to actually get certified as welcoming. We also need to decrease the fear of participation, right? So many of these kids face fear day in and day out, and we need to help spread trust. And in order to spread empathy, one way that we can do that is through bystander trainings, right? And so these are often offered at a community center or at a church or something, but they bring in just generic people from the community and talk about, whether it be specifically to unaccompanied kids or whether it be more globally to immigrants, but talking about you know, the stories and what people have gone through, but most importantly, talking about their assets, talking about their desire to be here, what they bring to the community, and all the wonderful ways that we can engage with these kids so that we can really build an appreciation, so that we can build empathy, so that we can build a partnership, right? That that these aren't people we need to look down on, but that these are our neighbors and they're going to be our doctors one day, or they're going to be the lawyer representing our case. And so we need to start that education early to really change those negative connotations in our society, to really change the narrative that we see. And then establishing partnerships that will lead to kind of long-term success, right? So a lot of these kids are coming here because they're fleeing something, but many of them have kind of subsequent reasons for coming, of reunifying with family, of seeking education, of seeking employment, right? So doing what we can to offer paid internships. A paid internship is going to be more likely that you're going to take it than working as a cleaning person or babysitting or something else that you need to do for income, right? Working under the table, but it will lead you to more career growth. We all know that about internships, right? Creating more access to trade schools and certificate programs. So we saw through this research that some kids weren't eligible because of legal status, others because of the timing of year of applications, right? That they come and maybe the certificate program starts in 2 or 3 weeks, and having to wait an entire year is unrealistic. So working with local programs to be more flexible, to understand these kids. And then, figuring out how and what's the appropriate way to share information on college. Not everyone wants to go that route, but some do. And so how do we educate on what are majors? How do you pick one? What are the career options? Why bother going to college, right? And then more specifics of the college application process, especially if you qualify for DACA or just in general or undocumented, right? A lot of community colleges and state colleges have specific application procedures for these kids. And of course, taking local tours, because it really oftentimes gets people excited, right? And it can answer the questions right there. So encouraging kids to go and at least explore the options. A couple recommendations in terms of collaboration. Most importantly, do it proactively, right? So networking on a regular basis, whether that be one-on-one or attending community meetings, attending community events, going to the local coalition, or creating a coalition if there isn't one in your community, right? But we need to establish relationships with our peers who do similar work or with similar populations. And really that can help to promote a continuity of care, right? These kids at Border Patrol, then in their shelter, then maybe in a long-term shelter or in a long-term foster care, they're questioned and they're processed over and over and over again. And whatever we can do in the community to decrease that need to continually be going through an intake process, to continually be assessed, but to share some of that information and provide more continuity of care is really beneficial in the long run, especially in terms of re-traumatization. And then with our collaborators, co-hosting events, sharing resources, and collectively identifying what the gaps are in your community so that somebody can then pick up the pieces and meet that need. So in terms of good referrals, right, of course, we want to be looking for agencies with language and cultural knowledge, bilingual, bicultural workers, absolutely. Unfortunately, that's not always available, right? So when it's not, we want to be thinking about who are you referring to and how do we help build up those organizations? So inviting them to things like today's training, hosting a training with a local immigrant or refugee serving organization, with a local professor or researcher who does work in this area, whatever it might be. And like we said on the last slide, in collaborations, bringing as many people to the table to do that training together, right? To open the doors for communications amongst service providers. Of course, screening for availability, referring someone to a place with a 6-month or a year wait list is not terribly effective. If that has to happen, finding something interim, informal mental health in terms of mentoring or something like that in the short term can always be beneficial. Logistics, right? How long does it take to get across the city, taking the bus or walking? Can parents bring their kids with them? What hours are they open? What do work hours and school hours look like? Taking those into account. When possible, going with the client to make an introduction person to person, right? To show that you trust the service provider on the other end, to make them feel comfortable going in can be really helpful. Especially if you've done that networking, right, that we just talked about, then it's your friend you're going in and you're giving them a hug or a shaking of a hand, maybe post-COVID, and you're showing that appreciation and that understanding and that trust that you've built between each other. And then most importantly, making sure that it's a good referral after the fact, right? So following up with people that have used it to assess, was it a good experience or not? What would they change? To determine if you make future referrals there, or if you need to go back to that beginning and thinking about ways that that agency can improve, and how do we do that collaboratively? And then I'm just going to talk for a brief minute about schools, right? So we saw them mentioned in both of the previous presentations today, and I'm mentioning it again. And so why is that, right? We see that school is one of the first places that these kids get into the community, and it's really where the acculturation process starts. It's where these kids begin to feel like kids again. So many of them have been taking on parental duties and household duties, right? So this is really bringing everybody back together as a child. So we need to think about some things at the school level, right? Making sure that our bullying prevention programs are culturally responsive, establishing adjustment programs or specific after-school programs for newcomers, making sure that tutoring is available, advocating for trauma-informed care, which we've already heard about today, creating welcoming policies and policies around grade placement. So I think that was briefly mentioned in the first presentation, but this idea that kids come often with less education than their age. And so figuring out how to make that decision, where do kids get sent. In terms of the students, providing an orientation to school, where's your locker, how to open up a locker, what happens at the class transition. That can be very, very stressful for a lot of kids. The bell rings and then there's hundreds of people in the hallways all moving around together. Also lunch clubs, food was mentioned earlier too, but in terms of making it a sharing and learning experience rather than something that can potentially lead to bullying or stigmas. Asking for extended learning time for English language learners. And then, going down the road further for assessment when more educational supports are needed, but when educational supports are needed, not when it's just a language barrier, right? So rather than labeling a kid with an IEP too soon, figuring out, what is that fine timeline? Like you can't wait too long if you're not understanding, but you also don't want to jump to that if it's more language than learning disabilities. So just kind of one-on-one, making that individualized for each kid. Of course, mental health supports and peer engagement. And then the last thing here is just to think about the parents and the caregivers, right? Many kids that are unaccompanied end up with parents, but also many end up with caregivers of other forms, aunts, grandparents, friends, neighbors. So thinking about welcoming all those people into the schools. Explaining the norms and kind of what we expect around school engagement from a parent or caregiver, because that often looks very different than home country. Translating forms and resources, of course. When you do that orientation and that kind of tour of the school with the kid, bringing the caregivers in, perhaps even the siblings in, right? Let everybody see where you're gonna go, understand the school, build that trust that the school is a safe place and that they know what's going on. In terms of providing orientation to instructional programs, what I really mean here is high school and kind of credits towards graduation, but understanding that process of what do kids have when they enter, what do they need to leave, and how do they accrue credits, right? What does it matter? How do you choose classes, things like that. If your school district is lucky enough to have parent liaisons, utilize them by all means. If you don't, advocate for them and advocate for bilingual, bicultural parent liaisons based on kind of the populations that you locally serve. So just as a sum up, right, kids belong to a lot of different communities, their family, their neighborhood, their school, their leisure activities. And we really need to be reducing barriers across all of them. That's our role as service providers, right, is to reduce those barriers. So I'm going to turn it over here.
Thank you so much, Dr. Evans, for your great presentation. We will have 5 minutes for Q&A for Dr. Evans. Cindy, can you help us with that?
Yes. So the first question says, what other recommendations can be given in cases where children's removed from their homes having contact with their parents begin to present behavior problems such as defiance of the foster family, irritability, and others behavior problems?
Yeah, I mean, for sure, if a kid is removed, there's going to be some resentment right there. And so I think depending on the age, it's understanding the reasons for removal and the process of hopeful reunification, right? Older kids, you can explain that more and they can get more involved in the process than perhaps a younger kid who's going to just act out because they don't understand where's my mom. But kind of developmentally working with them and building that trust and rapport in the foster family so that they can feel safe there and that they can engage in that place. And you know, of course, if it's safe, maintaining communication both in person and telephone and things like that throughout that time of separation.
Thank you, Dr. Evans. The next question reads, what is happening with the housing and care of unaccompanied minors? I don't know if you mentioned something about that.
In terms of kind of at the border, I think if we want to wait for that for the next segment, I have a graphic I can show, but I don't have the slide right now. But it kind of goes through how kids are processed. But I think, you know, largely right now there's a huge number of kids at the border, and so a lot of them are unfortunately being placed in emergency shelters, at least in the interim of figuring out what's next due to the social distancing policies that we have right now.
Perfect, thank you, Dr. Evans. We will now continue with the presentation and we will have a Q&A at the end. The next slide is about our webinars coming up next. We'll have Dr. Evans on May 5th regarding strategies to increase community participation of unaccompanied minors. We'll have then Dr. Rob Hudson on May 12th, mental health assessment for unaccompanied minors in the US. And we will also have Dr. Rosaura Orengo on May 19th, evidence-based trauma-focused interventions for unaccompanied minors. They will have a whole hour presentation trying informing deeply about the information that they share with us today. We will also want to highlight our products related to the indigenous population, Hispanic indigenous population. We have specific products for Guatemalan Mayan families, Mexican indigenous families, and we also have Northern Triangle indigenous populations in the next slide, and the Ecuadorians, Peruvians, and Nicaraguan indigenous populations. Now we will have the Q&A. Cindy, please help me with that. Thank you.
Thank you, Christine. So I'm gonna go ahead and make the first question for everybody, and then I'm gonna make one question for each so that we can answer a couple of those. So this is for everybody, but Dr. Orengo, you can start once I read the question. So the question says, are there any mental health assessments that are more culturally appropriate for unaccompanied children that might come from the countries they represent?
Sure. So a lot of the work that I've been doing in my research has been using the CPSS, which Dr. Hansen mentioned. It's one of the few measures that's been examined in Spanish-speaking countries, and our team has adopted that version and is about to publish a paper of the El Salvador Spanish version and Puerto Rico version. So that's one measure that I think has a lot of validity. And the other one is the Strengths and Difficulties Questionnaire, which was discussed. So I don't know if Rob, you want to add to that.
Yeah, thanks. Thanks, Rosaura. So the finding that that I spoke about with the CPSS was really unique, especially how those symptoms of PTSD emerged on those three profiles. One thing that I will note is that that's a really important area for future research. Rosaura, please, I would love to read your paper. So if you could send it to me, I'd love that. We really want to expand that area of research to see if those findings are replicated or if there are differences that we can explore further. But the sample that I was looking at was under 200 unaccompanied minors. So in terms of the CPSS, I think that's a really important area for future research. And with the SDQ, that's been used widely with unaccompanied children in the context of Europe, as I mentioned. But then Rosaura's paper is coming out. I'm starting to collect more data, or starting to gather data regarding use of the SDQ to kind of see how well it captures psychosocial well-being with this population here in the U.S.
And briefly, I want to add, Rob, to what you just said. The revised RCADS, revised Child Depression Anxiety Scale, which is also public domain, has a lot of research showing its effectiveness in Spanish. And so I can share with the MHTTC the 2 pubs that are coming out of our lab with over 3,000 youth in El Salvador documenting that it works, that it tapped into what we're trying to get at, and they're very easy to use. So very good question.
Thank you. Dr. Evan, I don't know if you want to expand on that question. No? Okay. I'm going to go ahead and read a question for you. And the question says, how did unaccompanied youth fare on the prosocial behavior scale? What resilience factors were noted?
That might be a good one for Dr. Hassan again.
I'm sorry, you want me to repeat? Sorry.
Yeah, that sounds like it was a question about the SDQ, the prosocial scale. Yeah, so what specific?
I'm sorry.
No, that's okay. That's okay. When I'm looking at the prosocial scale, one thing that I'm particularly looking at is one of the questions asks about friendships. Does the minor have a friend? And what we know from a trauma-informed perspective, one of the most important factors influencing someone's managing of their trauma symptoms is the extent to which they have a loving and supportive relationship with a caring adult. That's incredibly important. The prosocial scale asks that specifically. So that's one item that I would pay very close attention to on the prosocial scale.
Thank you, Dr. Hassan. I'm sorry, I think this one is addressed for Dr. Evans. It says, do you see a significant difference between children being released to relatives or others they know versus to them, fostered by strangers?
So I haven't seen research comparing those, and I don't know if anyone else has, but from kind of a practice perspective, I would say we definitely saw, you know, nuances. I don't know that it was necessarily one compared to the other, right? But that kids being released to parents or close family, yes, often had some relationship with them, but also oftentimes it's a strained relationship. You've been apart for 4 years, 6 years, 10 years. And so you only know each other through the telephone or through a webcam if you were lucky enough to do that. And so there's often kind of reunification struggles regardless. And I think, you know, in general, we think of foster care in this country, unfortunately, is not that great. But the outcomes and the research that we have done on the foster care programs that serve these kids is better, for sure. I mean, there is data comparing the two systems, and the outcomes are better. And I think that's largely because of the care and the what goes into like preparing those foster parents. So they're all given state-based foster care training and specific training for immigrants and refugees, right? Same with the staff members. And everyone goes into it with their heart 100% in it, right? Like it's, you go into serving this population or you go into domestic foster care. You have to make a choice. Most foster parents aren't in both. So we do see good outcomes there. I wouldn't necessarily say it's better than a parent, of course, right? But I haven't seen anything that compares like a parent versus aunts. I know that they're treated differently in the assessment process to be released based on the type of relationship. I hope that answers the question.
Yes, thank you, Dr. Evans. I'm gonna go ahead and make a general question. So feel free to answer any of you. So the question says, what can we expect of the situation that is happening right now in Numerous Convention Center, and they're asking if this has happened before, and if we know like the history or what was the outcome, like I guess from previous years of, you know, from history in general.
Could you clarify the question? I'm a little bit confused with convention centers.
Yeah, I guess they are asking in terms of like the situation that it's going on right now. What I guess they said convention centers, but I mean, I guess they meant like the centers where the children are right now. And in terms of like what have we seen in terms of history and how it has been handled in the past.
So I can speak to treatment, you know, so in terms of providing care to these unaccompanied youth who've been processed at the border, you know, and, you know, prior to 2012 where the numbers were lower and we had faster processing times, they've never been great. By the time they get to a trauma clinician, you see less dialogue and discourse about that process and more focus on traumas in home country or in their communities after being released. What I'm seeing now is more stories of the impact of being detained longer, of not having information, of being separated from siblings, of being cold. A lot of my kids talk about la hielera, so being in the freezer. A lot of the moms that I work with for trauma talk about, I don't know where my kid is. So that's what I'm seeing. And if history teaches us anything, is that we really need to attack this problem from multiple angles. It's not just individualized therapy, but at a systems level or at a policy level. And we know that separating kids from caregivers or not giving them information or housing them in inhumane conditions is not going to do anything for their mental health. It's going to make it worse.
I would love to build on your point, Dr. Orengo, and when with the increased numbers of children in detention at the border, this is where I think mental health assessment is so important because it will help us understand these children's needs, the minors' needs. As Dr. Orengo mentioned during her piece earlier this afternoon, children can respond differently to trauma, and not every child will need the same treatment to respond to a traumatic event. And the way that we can understand that is by assessing the ways in which they're exhibiting different symptoms. When we can have a more focused understanding of that, that will help us make the appropriate referral for that minor. I think that's going to be critically important as minors begin to enter into resettlement communities throughout the United States. And it will also help enhance the capacity of these communities, I believe.
Thank you both for answering the question. This is going to be our last question so that we don't pass our time. And it's addressed to everybody, so feel free to answer it. And the question is, what kind of therapeutic interventions are provided for the children at the border?
Dr. Evans, so I work with children not at the border. It's post-release with their sponsors. I would love to hear your thoughts at the border, what is being done.
Can you repeat the question? I'm not entirely sure I know the answer either.
Sure. The question says, what kind of therapeutic interventions are provided for the children at the border, if any?
Yeah,
I guess.
So at the border, not much, right? In CBP facilities, it's primarily law enforcement that they're with. There is a movement, luckily, to have social workers at the border doing some of the initial assessments, which is huge, huge, huge improvement, but it's going to take time before we have primarily social workers there. So I don't think there's much therapy happening right there. In theory, kids should only be at the border for up to 72 hours. and that's not always happen, unfortunately, but that's the law. After that, when they're released to shelters, there definitely is therapeutic available in a traditional shelter, typically once a week. But right now, where things are not in a typical rate, I don't know that they're meeting that, right? Like that's what the ORR policies and procedures says, is that it should be once a week. But my guess is that a lot of that's happening through group work right now rather than individual, and you know, it's hard to say honestly if that's being met, but by policy that's what they're supposed to be providing.
Right, exactly. And in an ideal world, what we want to see happening is what Dr. Evans described and Dr. Hansen, assessment, connection to basic coping skills and connections to healthy social supports, and then consider a referral to trauma-focused cognitive behavioral therapy, which is one of the most evidence-based treatments for trauma if we see it arise. And those are a lot of options, referrals at the border communities that have grants and centers that provide these services. And we'll talk about that in the webinars, individualized webinars we'll be giving.
Thank you
Lots of
so
work
much
to be done, folks. We need work in this area is the general message here.
Yes. Thank you so much for all your excellent work today, Dr. Rosaura Orengo, Dr. Kerri Evans, and Dr. Rob Hanson. We are very proud to have you as part of this webinar and having your individual webinars during May. Please remember to fill out the evaluation. You will have the barcode here that you can scan with your smartphone, or you will receive the link in the chat box. And also you will receive a link after the webinar ends to complete the evaluation. Please, please, please complete it. It will allow us to do presentations that are pressing and that are interesting for all of you, our audience. So thank you so much.
This was fun. Thank you so much for having me.
Thank you so much.
Thank you, everyone. Pleasure to be here.
Yes.